Well, hello everyone. Welcome to the All Things Celiac webinar series brought to you by the National Celiac Association and the Harvard Medical School Celiac Education and Research Program. We have a great topic and a fun title for today's presentation. It's I'm Diagnosed, Now What? Tracking Progress and Monitoring the Patient with Celiac Disease. My name is Chris Rich. I am the CEO and Executive Director of the National Celiac Association. We at NCA provide educational resources to our celiac community, such as this All Things Celiac webinar series, and we continue to value the opportunity to work in collaboration with the Harvard Medical School Celiac Education and Research Program to bring such initiatives to you. In addition to our educational programs, the National Celiac Association offers extensive support networks that reach from coast to coast and assist everyone from kids and their families to our celiac seniors. You can find more information about the ways that we act as the voice of the community on our website at nationalceliac.org. The highly collaborative Harvard Medical School Celiac Education and Research Program was founded in 2013 and has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. Education is at the heart of the HMS Celiac Education and Research Program, and these webinars continue to feature multidisciplinary speakers with specialized knowledge on celiac disease, related autoimmune conditions, and nutrition. So for today's event, you're welcome to ask general questions through the Q&A feature, which is located at the bottom right corner of your Zoom screen. You'll also see down there the closed caption button that's available by clicking on that CC. For those of you who have registered for continuing education units, please fill out the survey that's going to be added to the chat box during the webinar itself. If you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org. So that's digitalmedia@partners.org. Or you can reach us by phone at 857-282-6470. This session is also being recorded and will be available for viewing on the National Celiac Association's website, and that address again is nationalceliac.org. Our moderator today is Dr. Kieran Kelly. Dr. Kelly is a professor of medicine at Harvard Medical School and the J. Thomas Lamont Professor of Gastroenterology at Beth Israel Deaconess Medical Center in Boston. Dr. Kelly has engaged in patient care and research for more than 30 years and is an internationally recognized expert in the diagnosis and management of celiac disease. In 2004, he was the founder of the Celiac Center at Beth Israel and continues to serve as its medical director. In 2013, he co-founded the Celiac Education and Research Program at Harvard Medical School. He is a founding member and the past president of the Society for the Study of Celiac Disease. He's also the author of more than 300 clinical and basic research publications appearing in journals that include Gastroenterology, The Lancet, and the New England Journal of Medicine. So I am now happy to say welcome, Dr. Kelly.
Chris, thank you for your kind introduction, and it's a great pleasure to speak to everyone this afternoon. Our first speaker will be Dr. Maureen Leonard. Dr. Leonard serves as the clinical director of the Center for Celiac Research and Treatment at Mass General for Children's. She is assistant professor of pediatrics at Harvard Medical School, and in her clinical work, she treats adults and pediatric patients with celiac disease, non-celiac gluten sensitivity, and other gluten-related disorders. She is a graduate of New York Medical College. She completed her residency in general pediatrics at Tufts Medical Center in Boston and her fellowship in pediatric gastroenterology at Mass General for Children. She holds a master's degree in clinical and translational investigation from Harvard Medical School and is board certified in pediatric gastroenterology. Dr. Leonard's research is focused on predicting and preventing celiac disease through the NIH-funded Celiac Disease Genomic, Environment, Microbiome, and Metabolomic Study, which aims to identify microbial signatures that may predict the onset of autoimmune disease in an international prospective cohort of infants at risk for celiac disease. Dr. Leonard will speak to us on monitoring celiac disease. Thank you, Mo.
So thank you for the introduction and the invitation to speak today. And as Dr. Kelly said, I will be talking about monitoring recommendations in pediatric and adult patients with celiac disease. These are my disclosures. They are not related to what I'll be talking about today. And I will be focusing on following up and monitoring recommendations for patients with celiac disease, I'm going to discuss a bit about mucosal recovery in patients with celiac disease, and then describe non-responsive celiac disease and current treatment options for that condition. Since I am a pediatric gastroenterologist, I'll be leaning a little bit more towards the pediatric side, and we'll hear more about the adult side later as well. So, strict adherence to a lifelong gluten-free diet is the only effective and available treatment for celiac disease. Mucosal recovery is a main goal of celiac disease management, but currently there are no guidelines for routine follow-up endoscopy with biopsy to assess the mucosa. Current management guidelines suggest repeating diagnostic serologic studies every 6 months or until they normalize, or yearly. But studies show that this serology is not predictive of adherence or mucosal recovery. So how do we follow patients with celiac disease? This is a figure that I altered from a recent review by Dr. Tai Din on this matter, and then I modified it slightly to include children based on pediatric guidelines. So for the purpose of this talk, I'm going to skip this area, which is what we do at diagnosis, and focus on the time period after diagnosis. So patients with celiac disease should be seen by a physician and a dietitian 3 to 6 months after diagnosis, and then every 6 months until TTG levels normalize. At the time of follow-up at both the 6 and the 12-month visits, one should assess and discuss mental health. They need to reassess signs and symptoms, assess growth in children, repeat celiac serology, and then any abnormal labs. And then dietary adherence should be measured by dietary interview, questionnaires, and a combination of symptoms and labs. Once TTG is normalized and patients are feeling better, they should be followed by a yearly by a physician and dietitian. And again, the same assessments regarding mental health, signs and symptoms, growth in children, laboratory studies, and dietary adherence should be addressed. At 1 year after diagnosis and beyond, there should be consideration of repeat duodenal biopsy in certain cases, and we'll talk more about that a little bit later. And so that's a very helpful roadmap to sort of guide how we should manage and follow our patients. But we still have sort of a major issue in celiac disease, is that we really don't have an accurate, non-invasive biomarker to follow patients with celiac disease. And so we use a combination of markers. So we assess symptoms, but we know that 30% of patients might be asymptomatic at diagnosis. And then we and others have shown that symptoms don't necessarily correlate with mucosal damage when someone's on a gluten-free diet. We have dietary assessment and questionnaires. We're going to hear a lot more about that towards the end of this webinar. But these to date have not been standardized, and it's often hard to tease out exposures. We can use gluten immunogenic peptides. I'll talk a little bit more about this in the next slide, but these are things that we can look at for in the urine or stool to look for gluten exposure. We're starting to use this more in practice, but it's not currently covered by insurance or offered by hospitals. So it's something that we have to do with patients on their own, at least in the US. Guidelines suggest we follow serology, and while positive tests might be suggestive of exposure to gluten, numerous studies, including our own in children, have shown that negative studies and negative tests don't predict adherence to the gluten-free diet or mucosal recovery. We do have this objective marker, that's a duodenal biopsy, but it's invasive. It has its own issues. We know there may be sampling errors in orienting the tissue, and then we don't have full agreement on what defines mucosal recovery. So just to talk about the gluten immunogenic peptides, we're using them more in clinical practice and in trials. These are fragments of gluten proteins that are resistant to digestion, and tests are available to purchase online because we can detect them in either urine or stool. And there's been some work looking at this that showing that really despite our best efforts, gluten exposure is still common in a gluten-free diet. So Dr. Sylvester at Boston Children's published a doggy bag study in adults and found that about 66% of 18 adults that she followed who had been on a gluten-free diet for 2 years had measurable gluten exposure in a 10-day period. Another study showed that and we have it over here, that GIPs were present in 97% of children at diagnosis of celiac disease, which we expect because most of them are eating gluten before diagnosis. This decreased to about 13% after 6 months on a gluten-free diet, and then increased to about 25% by 2 years on a gluten-free diet. And then we've done some work in collaboration with Boston Children's, which looked at the role of GIPs in children as indicators of dietary adherence and predicting histologic recovery. We looked at using GIPs in a couple of different settings, at home, in the clinic, and then prior to endoscopy, to sort of get a sense of how we might use them in practice. We detected GIPs in about 9% of stool samples, about 5% of urine samples, and most of these children who had GIPs in their urine or stool were asymptomatic. We had 12 children that had persistent enteropathy, so persistently active celiac disease despite a gluten-free diet, but they didn't have any detectable GIPs in their urine prior to their endoscopy. So this could be for a couple of reasons. One also is this is just a one time point, one snapshot in time. So we probably need more than one test to really get at whether people are being exposed to gluten. So in thinking about the healed small intestine, this is again the goal of treatment, one of the goals of treatment, along with symptom improvement. We still don't have even a term, I think, that we all use to talk about this. So we can talk about mucosal recovery or mucosal activity or mucosal healing or celiac disease in remission. So some of this needs to be settled. I think for this talk, I'll try to refer to it as mucosal recovery or persistent enteropathy, meaning persistently active celiac disease. And then we'll define it according to Marsh criteria, which evaluates the histology for intraepithelial lymphocytes, crypt hyperplasia, and villus atrophy. So this is how we look at celiac histology. So mucosal recovery in general will be defined as having normal duodenal mucosa, or MARSH1, which is a non-specific increase in intraepithelial lymphocytes. And persistent enteropathy will be defined as mostly MARSH3, which is villus blunting, and in a few cases, MARSH2, which is an increase in intraepithelial lymphocytes and crypt hyperplasia. So when do we expect improvement of things like signs, symptoms, histology of these biomarkers? I don't think we have enough information to know for histology or the duodenal mucosa, but symptoms and biomarkers usually recover in different time frames. And this is a great figure by Dr. Elli, who will speak next, but it shows that really we expect symptoms to improve over a period of weeks to months compared to the serology, which will take months to up to a year, and then histology could be quite a bit longer. So we define mucosal recovery and persistent enteropathy according to the histologic findings and Marsh criteria, but can we use any non-invasive methods to predict villus atrophy? I'll say a couple times through this talk, and I've mentioned before that guidelines suggest following serology markers, but the sensitivity and specificity of the IgA-TTG and the IgA-EMA is really not adequate to identify and determine who might need additional treatment for persistent enteropathy. Studies also show that dietitian evaluation and validated adherence scores have a lower sensitivity to identify patients that have persistent villus atrophy. And yet again, routine follow-up biopsies aren't recommended for all patients in any management guidelines. So guidelines recently published by Dr. Elli and others suggest that we should be considering a follow-up biopsy in patients with persistent signs and symptoms. And again, I will include in children, if there's poor growth or slow growth in children, we need to consider a repeat biopsy. If there are any red flag symptoms, so diarrhea, weight loss, signs of malabsorption, the development or persistence of hematologic deficiencies, such as anemia, which we would expect to get better after a year, persistently positive serology, even despite careful review of the diet with a dietitian. And then we should consider patient choice or preference if they want to make sure that they have intestinal healing. And so for those undergoing a repeat biopsy, how should the physician assess for mucosal recovery and mucosal activity? So To date, the study suggests that the ideal timing of a repeat biopsy is 1 to 2 years after diagnosis, unless there are concerning signs or symptoms that prompt an earlier endoscopy. Like at diagnosis, biopsy should be obtained from both the bulb and the second portion of the small intestine. This for the endoscopist is best if you can take one biopsy per pass, but that's not always possible. And then you can consider other methodologies to ensure that you're collecting samples from areas that look to have damage if there is any present. So we don't have a, truly accurate non-invasive biomarker for follow-up, and that's important because we really know that the gluten-free diet is very difficult to follow. While the majority of patients get better on a gluten-free diet, not all do. So non-responsive celiac disease is defined as the presence of persistent symptoms and/or enteropathy despite 6 to 12 months on a gluten-free diet. Data in adults suggests that up to 30% may have persistent symptoms, and 30 to 65% may have persistent enteropathy even after 2 years on treatment. And the complications associated with this have been suggested to be and shown to be nutritional deficiencies, osteoporosis, and increased risk of hip fracture, and rarely lymphoproliferative malignancy. In children, the definition is the same, but we have much more limited data. One retrospective study from Boston Children's Group found about 15% of children with celiac disease on a gluten-free diet have persistent symptoms. And then we published some work a couple of years ago in collaboration with BCH that showed up to almost 20% may have persistent enteropathy after 2 years on a gluten-free diet. But we don't really know the consequences of this in children. It's possible that they might be similar to children with undiagnosed celiac disease. So issues related to growth, nutritional deficiencies, poor school performance, and dental enamel defects are all possible, but we need additional studies. We have some new data under review from 8 pediatric centers from the US and Canada. In this work, not yet published, we evaluated 130 children with celiac disease on a gluten-free diet who had a repeat biopsy within 15 months of their diagnosis and starting a gluten-free diet. And our goal here was really to begin to understand the natural history of mucosal recovery. We found that about 74% in that 15-month time period had mucosal recovery. Interesting, about nearly 50% of children who had an endoscopy within 3 months had mucosal recovery, and overall about 26% had persistent enteropathy. When we looked at any predictors or things that were associated with persistent enteropathy, we saw that a greater proportion of children with persistent enteropathy had poor weight gain or weight loss, or joint-related complaints on initial presentation compared to those who had mucosal recovery. And when we look at our recent data sort of in a different way, we can see that 60% had mucosal recovery within 6 months. About 80% had mucosal recovery within 1 year. And that's compared to adult data where we see about 53 to about 70% of adults have recovery in that same time period, which suggests that children heal earlier or faster and may have more mucosal recovery compared to adults. And this has been echoed in other studies. So this is another recent study published earlier this year where gastrointestinal pathologists from 13 centers evaluated retrospectively collected paired biopsies, so from initial biopsy and follow-up biopsies. And they wanted to correlate the findings with serology, symptoms, age, and gluten-free diet adherence. So you can see here, unlike our study, which was very early on in the 15 months after diagnosis, here they looked at patients who had a repeat endoscopy, an average time 3 years after diagnosis, and the range was anytime between 1 year and 18 years. Again, their aims were to look at the presence of persistent enteropathy and also see if there were clinical factors that could predict recovery or injury. And here there's 2 figures. This is the Marsh score at follow-up. So histology score, lower is recovery, and this is persistently active disease in children less than 17 compared to adults. And this is the number of increase in the intraepithelial lymphocytes, or the white blood cells in the small intestine in children and adults. So again, here we can see that persistent enteropathy overall was common. Children were more likely to show normalization of Marsh score and IEL counts compared to adults. And again, serology symptoms and gluten-free diet adherence, reported adherence, did not predict mucosal activity status.
2 minutes, Dr. Leonard.
Thanks. So just looking at what we know about risk factors for persistent enteropathy, for adults, we know that there are risk factors such as severe disease, having a repeat biopsy sooner after diagnosis, weight loss, lower education, and those using PPI, NSAID, or SSRI. They're all risk factors for persistent enteropathy. For children, we don't know. We've seen some association with weight loss and joint complaints, and multiple studies, again, have showed symptoms and serology don't predict this. So moving towards how do we evaluate and manage these patients who don't have mucosal recovery, we take a systematic approach. So we want to review and make sure that the initial diagnosis is correct. We want to make sure that they're not exposed to gluten by having them meet with our dietitian and consider GIP testing. And then we want to consider other medical etiologies. If those things have been ruled out, it's time to assess for non-responsive celiac disease. There are treatment options for non-responsive celiac disease. One is a gluten contamination elimination diet. The other is the use of budesonide, and there's a particular open capsule protocol that's used and has, as you can see, a very good response rate. We've looked at both of these two treatments as well in children, and we've seen that about 46% who have non-responsive celiac disease will respond to the gluten contamination elimination diet, and 89% will respond to budesonide and then be able to come off of these treatments and return to a gluten-free diet. So to wrap up, there are definitely some differences when we think about children and adults when it comes to mucosal activity and healing. In school-age children and adults, we think that about 75 to 80% will have mucosal recovery after 2 years on a gluten-free diet, compared to about 60% of adults. So focusing on the future of follow-up assessments, we really need to better understand the mucosal recovery, the frequency of non-responsive celiac disease, the frequency of persistent enteropathy. We need to improve our follow-up and develop more accurate biomarkers, define healing as a community. It's important to know that there are new therapeutic options in the pipeline, and so follow-up is more important than ever. And this is my last summary slide. So again, I think we need more biomarkers of mucosal recovery. We should take a systematic approach to non-responsive celiac disease. And really, other treatments are under development. So let's try to better understand the extent to which these are needed in children and adults. Thank you.
Hi, thank you so much, Mo, for an excellent overview, a very comprehensive overview. And we'll move on now to our second speaker, who is Luca Elli. Elli received his MD degree in 2000 from the University of Milan, and completed his specialization in gastroenterology and endoscopy in 2004 at the University of Udine. Between 2004 and 2007, he completed his PhD program in gastroenterological sciences at the University of Milano. His main areas of expertise are celiac disease, small bowel endoscopy, and nutrition. He is chief of the Celiac Disease Center and director of the clinical nutrition team of the IORCCS Foundation Sagrana Milano at the University of Milano. Luca is widely recognized as an expert in celiac disease diagnosis and management, and is the lead author of a very recent publication providing consensus guidelines from an international panel on best practices for monitoring celiac disease patients after their diagnosis. And this guideline document is published in Nature Reviews, Gastroenterology and Hepatology. Dr. Elli will introduce us to those expert guidelines in his talk. Thank you.
Oh, thank you. Thank you very much, Sharon, for this very kind invitation. Thank you, all of you. And it's a great honor to be here with you, also virtually. Now we're going for the next minute through, the main recommendation that we have posed together with the European North American Society for the Study of Celiac Disease in the monitoring phase of celiac disease. These are my disclosures, and we know that for the diagnosis of celiac disease, we have a lot of guidelines from different countries and continents, and we all agree in flow charts to make the diagnosis of celiac disease. And to be honest, in 95% of cases, celiac disease is not such an hard, diagnosis to do. Different is when we move in the monitoring phase. After diagnosis, we start, probably for a long time, a monitoring phase of celiac disease. And here, to be honest, it has been very hard to produce these guidelines that are, a great system based on evidence, because we have very few evidence, very few paper, and so it's a very difficult phase from the clinical side, also from the patient side, of course, but also from a physician, because we have no very very scientifically based, evidence-based approach. What happens normally? Of course, we have a patient with symptoms, we have a patient with probably positive transglutaminase antibodies, and we have, if we make the biopsy in adult, now it's still suggested, we have a duodenal damage, a duodenal atrophy. All these factors make the diagnosis of celiac disease, and once we make the diagnosis of celiac disease, we start with the gluten-free diet. And so we pass from a diagnostic phase to a monitoring phase. Okay, this is the passage. And what we do now is to use the same biomarker that we use for diagnosis to monitor this biomarker, during the monitoring phase. But it is correct, this approach. We are going to analyze this fact. What we expect, and the patients expect, from the gluten-free diet. Of course, the regression of symptoms. Of course, to normalize the antibody, the serology, and recovery of the duodenal mucosal damage. These are, the main endpoints. We have more wide long-term goals that, of course, is to prevent the complications that are rare in celiac disease, fortunately, but sometimes they are very severe from a clinical point of view. And we're speaking, of course, on lymphoproliferative disorder, but also other autoimmune diseases. Of course, to maintain the remission of the disease, to have a good quality of life. To live on a gluten-free diet is not always easy, especially from the social point of view, and in general to improve the health status, to feel better. Okay, these are goals, more general goals. Of course, it's a question of time. Maureen said before that symptoms, antibodies, and mucosal healings happens at different times. Probably weeks. The symptoms could be very quick. In children are quicker. Antibodies take months. Mucosal healings, I don't know, but it's a long story, the mucosal healing. So from this figure, you understand that we can't use the same biomarker at the same times. It depends how long the patient is on a gluten-free diet, and then we can in some way change the biomarker that we are going to use to monitor this patient. So this is a different. What we are going to monitor in a patient. As for IBD, for example, we monitor the therapy, the adherence to the therapy. That in celiac disease means the adherence to the gluten-free diet. And we monitor the activity of the disease, the celiac disease activity. Nowadays, the reference standard to evaluate the activity of celiac disease is, again, the duodenal histology. Where is the problem? These two factors not always correlate. We have sometimes patients strictly and very adherent to a gluten-free diet, but they still present an active disease. for example, refractory celiac disease. And we have patients also not completely adherent to the gluten-free diet, but in remission with the celiac disease. So these two factors not always go on the same way. So sometimes they not always correlate. So let's now go with the main recommendation of this paper that we published some months ago about how to monitor celiac disease. So the first point is, of course, the anti-tissue transglutaminase or type 2 AGA antibodies. It's the non-invasive biomarker most used for celiac disease in the diagnosis and also in the monitoring phase. So the two factors that you want to monitor in celiac disease are adherence to the gluten-free diet and mucosal recovery or celiac disease activity. So can we use anti-tissue transglutaminase to evaluate the adherence to the gluten-free diet? So and so. Because, if they're positive, probably it means that the patient is ingesting gluten on a large quantity. And I'm speaking of voluntary ingestion, basically, okay? Not contamination. But if they are negative, it doesn't mean that there is no gluten in the diet. So we can use, but with some problems concerning its positivity and above all negativity, because if they are negative, we can't exclude the presence of small amounts of gluten in the diet. Of course, as we said before, they take time to normalize. They can take months, but also sometimes years. So it's also in this case, we have to verify where we are. How long is the gluten-free diet for these patients? And another point is so important, the single titer of tissue transglutaminase during the monitoring phase? Probably not. What we have to observe is the trend all along the years after starting the gluten-free diet. In this paper, we try to subtype, the tissue transglutaminase trend in 3 classes. First, class 1 are patients with a progressive decrease of the gluten-free diet. They take time, but progressively decrease of the titers. In the class 2, we have, such fashion. We have, a titer that is going up and down, but, not so distant from the cutoff value. In general, they maintain a borderline value. And we have the class 3. The class 3 is patient with a steady state or increasing the tissue transglutaminase while on a gluten-free diet. This class, we have to pay attention, probably, because these are patients most probably with GAP, with the gluten immunogenic peptide positive in urine or stool, and are patients that probably are ingesting gluten involuntary. So when we have this trend, so it's a question of time. We have to have not a single dose, but multiple dosages. If we have this trend, maintaining the same level or increasing, probably these are the patients you have to pay more attention, okay? Because probably they are not completely adhering to the gluten-free diet, voluntary or not. So we can, if tissue transglutaminase antibody, it's not so important to evaluate as a single dose to evaluate the adherence to the gluten-free diet. Are they important to evaluate as a surrogate, of duodenal atrophy? In other words, can we use the titer of IgA to investigate if there is still a duodenal damage during the monitoring phase? Absolutely not. Because as already, we already seen some slides about that. We don't have, it's a very low sensitivity for the detection of gluten-free diet of mucosal atrophy in the monitoring phase. So we can't use tissue transglutaminase as a non-invasive marker of duodenal atrophy. This is not the scope of tissue transglutaminase. But during, we usually visit the patients every year, 1 per year, but we don't dose only tissue transglutaminase. We also make some biochemistry and other tests. So we recommend the use of, routinary tests and vitamins and micronutrients to evaluate the quality of the diet of the patient if there is some deficiency, and also to evaluate the presence or not of some autoimmune comorbidities, such as autoimmune hepatitis. We usually perform transaminases or autoimmune thyroiditis, and that's why every year, for example, we dose the TSH hormone. So these are the points to make not only IgA anti-TG2, but also other biochemistry every year to the patients to verify if there is a deficiency of some micronutrients like zinc, magnesium, or vitamins that are very important in the metabolism of the patients, especially for bone, for example, and so on and so forth. So, what is the best way to monitor the gluten-free diet adherence? Of course, in this paper, we underline that it's very important the role of dietitian. Dietitian probably is, and dietitian evaluation is the best way to verify the adherence to the gluten-free diet, okay? And also to evaluate the quality of the gluten-free diet that the patient is following. So absolutely, dietitian is central in the monitoring phase of the gluten-free diet, of the monitoring phase of the celiac disease. Also at the beginning, of course, to make a counseling on how to do the gluten-free diet. Of course, there are also other tools that we can use because I don't know in US, but in Europe, dietitians are very rare. Not all the center have the possibility to have a dietitian who is specialized in celiac disease and gluten-free diet. So it could be a little bit difficult. So also questionnaire could be important if you don't have a dietitian, close to you in the room or not. And so they are very important instruments. Of course, the dietitian is better, but if you have questionnaire, you have to use it. Of course, more in an holistic approach, because we already know that questionnaire have a low sensitivity for duodenal atrophy. They usually don't correlate with tissue transglutaminase. So you can use questionnaire more in an holistic approach of the patients if you don't have a dietitian that can support you. So use it, but keep in mind that, again, there are instruments that don't tell you about the activity of celiac disease. But this kind of test, the GIP, the gluten immunogenic peptides, are becoming more and more important. They are very important now and will be more important, I think, in the future, because this is the first instrument that you can use objectively to look for the presence of gluten in the diet of the patient. So we recommend the use of GAP when there is a problem with the diet or there is a non-full response to the diet. So the first thing to do is, of course, to verify if there is a component of gluten in the diet and the patient is still ingesting gluten. So this instrument is very, very important. If you use it in the urine, of course, you cover, a time frame of 2 days, more or less, but you can use in the stool, and of course, you cover a longer time. It's very important. Now, the problem with this tool, basically, is that we don't have a very protocol that we can apply. For example, we don't know if you have to use a single dose, if you have to do multiple tests in the stool or in the urine. But I think in the future we will have a protocol also for this kind of test, and will be very important, of course, for the physician, but also for the patients who can verify itself if is following or not a good and strict gluten-free diet. Of course, we also make
2 minutes, Dr. Elli.
Thank you. Recommendation number 9, if can be used to verify the quantity of gluten. This is a little bit more difficult. In general, they are positive more in male than in females, and that's very important. GIP correlate with the duodenal atrophy. That's very important because it's the only test that now they correlate with architectural villus atrophy. Of course, it's very important, the quality of life. It's very important for the patients and for the clinicians. And in this statement, we want to stress the idea that we have to, of course, to monitor for a strict gluten-free diet adherence, but we don't have to induce an hypervigilance for the patients because, as demonstrated in this paper, it reduces the quality of life of patients. So it's very important that patients have to pay attention, but not be too much anxious towards, the adherence to the gluten-free diet. Of course, endoscopy is not routinely recommended because we know that we have 1/3 of patients, more or less, who maintain some architectural damage, although they have a functional recovery. That's the main important thing. So it's not routinely recommended. What is becoming very important, especially in the analysis of adult patients not responsive to the gluten-free diet, is small bowel capsule endoscopy. Because we know that most frightful, ulcers, malignancy, and so in celiac disease happens in jejunum and ileum, so are completely blind at upper endoscopy. That's why it's very important if you suppose that your patient is complicated, is very complicated, maybe, and you want to exclude, a malignancy of the small bowel, you have to go with the capsule to look at all the small bowel, because malignancy in celiac disease is always behind the thighs, so completely blind to upper endoscopy. And these are images from lymphoma or refractory celiac disease in celiac patients. These are, you can find in the paper this summarizing figure of what to do at what time frame. Of course, some things is evidence-based, some other is expert opinion, because as I told you, it's very difficult. We need research in this area for celiac disease. And what is going for the future in general, I think that patient will be more stratified depending on risks and so on. We need, of course, much more biomarkers, non-invasive biomarkers. Probably the evaluation of the gluten-free diet will be based on GIP. That will be more important in the future, and other form of non-invasive endoscopy as capsule, and probably supported by artificial intelligence, are becoming very important. And of course, molecular analysis will support the histology. No more only hematoxylin and eosin, but also other biomarkers. Thank you very much.
Thank you very much, Dr. Elli, for an excellent presentation and summary of the very recent expert guidelines. We thank you. Our next speaker is Anne Lee, RD, LDN. Anne is Assistant Professor of Nutritional Medicine in the Department of Medicine and the Institute for Human Nutrition at Columbia University, and she is the lead dietitian for the Columbia Celiac Disease Center. Anne is involved in patient care and research. Her research and publications focus on quality of life issues, dietary adherence, concerns for the nutritional quality of the gluten-free diet, and eating patterns and behaviors. The research on eating behaviors has provided insight into the impact of the rigidity of the gluten-free diet on eating patterns, and has created a paradigm shift in the education and counseling of individuals with celiac disease. Currently, she is working with an international group to define standards for nutritional assessment, education, and adherence of individuals with celiac disease. She is also the lead author of a recently published article on nutrition assessment of patients with celiac disease, appearing in the Journal of Human Nutrition and Dietetics. She will share with us how to assess and monitor adherence to the gluten-free diet for the best possible health outcomes. And thank you for speaking with us. And if you can share your slides, please.
Thank you. Thank you very much. It's an honor to be here and to get to speak with all of you and to be on such a fantastic panel. And as both Luca and Maureen had talked about, there's a lot of ways for us to look at monitoring, but from the, it focuses on the role of the dietitian, but we're going to speak today on what that role is and how it's evolving over time. These are my disclosures. It's the only disclosures I have are supporting grants from Takeda. What I'd like to do is kind of give you an introduction and an overview. We're going to talk about the diet, but when we talk about the diet and monitoring and adherence, we really need to think about kind of how we approach the diet and kind of where we are and where we're going. And we'll describe the changes in the approach to diet over the time. And then we'll look at nutritional assessment and how important that is. So our goal today is to really highlight the work that we're doing as a group and as a community to standardize that nutritional assessment, because as you saw from both Maureen's and Luca's discussion, the role of the dietitian is really pivotal in being able to determine how closely a patient is adhering to their diet. So let's start with kind of where we've come from. The history of celiac disease is actually interesting from a diet perspective. I mean, it was talked about back in ancient Greece where there was a family and one individual would fail while others thrived in the exact same environment, but they really didn't know the cause. As we fast forward to the 1880s, we see that Dr. Guy was able to identify there was an error in the diet, that there was something in the diet that was wrong. And one of the treatments was really this evolution of our banana babies, because they found that treating these infants with bananas, rice, and pot cheese cured them. And what it was is we were just removing that toxic agent. And it wasn't until the 50s that we really were able to identify what the food was that was causing these responses. Today, we know that it's an autoimmune response. There's an increased rate of diagnosis and awareness. However, what we find is that even though there's an increased awareness in the treatment of celiac disease, there's not an increased awareness in the actual performance of the diet or the instruction of the diet. So we're going to look at the gluten-free diet from the 1950s to now. In essence, back in the 50s, when we first identified this as a trigger, the diet was really based on natural gluten-free foods. So it was a plethora of fruits, vegetables, your proteins, all of these things that were basically gluten-free naturally. There were not many products. In fact, many people had to make their own bread. There was no crackers. There wasn't that aisle in many of the grocery stores that had, just so many gluten-free products on it. Now we see that it's really changed, but the shift is very interesting and very important because the shift has gone from foods that are naturally gluten-free, full of vitamins and nutrients, to things that are all mixes, highly processed, highly packaged, and, really anything you could want that you would want in to replace your wheat-based products you can find, but there isn't the same nutritional quality that there was in that basic diet. So the diet is the treatment, but we really need to look at what this treatment is. It's complex in that it requires, complete elimination of gluten. It's it's not like a diet for weight loss where I'll take a day off, I'll take a holiday. This is 24/7, 365 days a year. And we know that incremental exposure will cause incremental damage. But we also must consider that meals and food are very social. We think of food, we just, here in the US, just celebrated Thanksgiving, which is a celebration of family, friends, and giving thanks and being together. And it's all centered around food. And that's very important, that we need to really translate the research we've done on nutritional quality and quality of life into our research practice, okay? But with that, we found there's some issues in taking that research and translating into patient care. But first, let's look at the quality of the diet, because I think that's one of the major things that has changed from the 50s to now. But our education has not caught up with the changes that are happening, in our environment. A wheat-based diet is required by the FDA, any wheat-based product to be enriched to put back in the nutrients that are removed during processing. Unfortunately, that requirement by the FDA only applies to wheat-based products. It doesn't apply to any dietary products like gluten-free. So they're not enriched, and they typically use grains that are lower in nutrition quality. So even though the diet is the treatment is not as nutritious as the diet was as a wheat-based diet. In addition to the nutritional quality, there's also, as Luca highlighted, the quality of life issues surrounding the diet. When we think about how following a gluten-free diet impacts our patients, it goes from the cost of the food to the nutrition quality, to the ability to read those labels, to decipher them, to manage the diet in all aspects of our daily life, whether it's a work event, a school event, and even just access to the food. There are many places across the world where there are really gluten-free deserts in terms of availability of food, and we need to be able to address those. So what we know and where we started the project that I was asked to speak about, which is really standardizing assessment and adherence, is that, research studies have identified all these issues as being, really issues and barriers in terms of adhering to the gluten-free diet. But what we found is, as we were moving forward, is that we have all these barriers, which were in direct contrast to the guidelines that are being put out, whether it's the NIH, ESPGHAN, NASPGHAN. Everyone says there must be a dietitian available for counseling. But as Luca mentioned before, there aren't dietitians everywhere that are available for counseling our patients. In addition, we found the standard of care, even for the standard of care for dietitian evaluation and education, is not the same across the board. We in an NIH grant we're working on, in a multi-center grant with Beth Israel, Vanderbilt, and University of Chicago, and Columbia, we found that as the dietitians got together to create the program, that there was no standard in the assessment, and even the dietitian education varied from hospital to hospital. The amount of time that was spent in a patient visit, the consensus on how strict is strict, what foods are allowed even, and what foods to avoid varied from each hospital. And so we developed from that increased awareness a nutritional assessment project that was based here in the United States. And the importance of this project was really to be able to improve the care of our patients and to make sure that a patient, no matter where they were, is going to get the same optimum care and optimum guidelines and information that every other patient will be getting. So it's more than a project. It's really about building the future. And so what we did is we looked at different areas. We looked at nutritional assessment, we looked at adherence, and we looked at the education of our patients. And we found that in current practice, there was no consensus between even just these 4 celiac centers in terms of what would be used as an assessment. We found that there was differences in terms of what, blood work was done at what time, what the routine follow-up was. And so we really developed a template that was an inclusive nutritional assessment that any dietitian could use and go through to make sure that we're looking at the clinical markers. Has the patient had blood work? Are they doing those vitamin and mineral levels that Luca talked about? Are they, looking at the growth curves in our pediatric patients? Are they measuring them against time? What are we looking at physical activity of our patients? Are we looking at symptoms? Are we looking at intake? And we found that, even those psychosocial areas of assessment were often not included. And so we really developed this tool that would highlight each of these areas to make sure that in a standard dietitian evaluation, we would cover all of these aspects of the impact of diet on our patient's life. So we're able to not only give them, a thorough assessment, but we're going to make sure that we're covering what our research has shown are major barriers. What is their food insecurity? Does someone know how to cook? Does someone know how to read a label? That all these would now be included. As we developed this, we also realized that there's a wide variety in terms of practice of measuring dietary adherence. Again, there was no consensus between our 4 sites. And we looked at the different tools that are currently being used. And as both was pointed out by both Maureen and Luca before, thankfully, was that the lack of correlation between the standard assessment tools and histology and healing. There was even very little correlation between the standard assessment tool and even celiac serologies. So we developed a short form adherence tool that we feel would be very, very effective, both nationally and internationally. We did trial it in clinical use. We are implementing it in our NIH grant research project, and we had it, we're currently looking at that, and we're going to be able to compare the new adherence tool to histology at the end of the research project. So what's important is not just that what we're planning, but kind of how we did it and how we got here. We had a team of expert dietitians that were specialized in celiac disease, and we started with, similar to Luca's guideline pathway, with developing questions and identifying gaps in care and gaps in knowledge. Did a very extensive lit review through PubMed and Cochrane, had identified search tools that we each used, identified topics and questions, and then through a series of reviews, group discussions, developed a draft. That draft was then taken and given to external readers that were also, expert dietitians and gastroenterologists at other celiac centers. And we really wanted to make sure that we covered not just the area from our centers, but that we did it in both rural and urban areas, different parts of the country, so that we could really identify the patient concerns and questions nationally. So the questions of, what is celiac disease in the patient's mind? How does it affect you? Does the diet matter? What are the common threads? And so we grouped all these together and then had our external reviewers look at them from their perspective and their patient population as well. And then each dietitian and then the external reviewers worked as a team to really come up with a consensus. Besides that, there was, we then took all this information, developed a draft, again, went out to external reviewers, again, incorporated their edits and comments. And we just, as Dr. Kieran Kelly just mentioned, we just published our final white paper, which is a review and consensus statement where it really gives the guidelines for that standardized nutritional assessment and the draft of a new adherence tool. But with that, I have to say our work is not yet done. We have formed a new group of dietitians and gastroenterologists internationally. We had our first meeting in the UK in Sheffield in September. We are now working with a group to, again, establish a very rigorous lit review through the Delphi process. And we will be formulating, reviewing the assessment that we've developed, reviewing the adherence tool we developed, and actually going through and developing educational tools that will have a base standard that will be able to be used internationally with prompts and caveats to adopt for cultural needs. And so with this, we really see that for our patients, our key takeaways of the work that we've been doing is that for you to know that work is ongoing and that you really need to seek out healthcare providers who specialize in celiac disease and have the awareness of this new work that's being done so you get the best quality care. Aside from identifying those specialists, we really want to make sure that you seek your dietitian follow-up visits, you seek your gastroenterologist visits, you ask for your celiac serology to be done. But in addition, your vitamin and mineral status, your DEXA scan, work with your PCP to make sure that all of this is being done as part of your ongoing care. For our professionals, the ongoing training for dietitians, the Academy of Nutrition and Dietetics has a certificate of training for celiac disease. The information in there has just been updated. We have not incorporated our new assessment and things, but there's a very good assessment that's a part of that training program. There are webinars such as this. There's one tonight for the Society of Celiac Disease that will be covering some of this nutritional assessment information. Columbia Vanderbilt, each of these centers have ongoing education programs and conferences that I would encourage you to take part in. And scour PubMed, look at the newest publications, and make sure that you're aware of the changing field that is our celiac disease management and follow-up. And because there's exciting things that are happening, from Luca's work, Maureen's work, and even this dietitian-led work. So I want to say thank you. There's a special thanks to the team that made so much of this happen, and also to all of you for participating today.
Wonderful. Thank you. So I want to thank our three panelists for a series of absolutely excellent and comprehensive talks. And now we will move on to the question and answer part of our program. I will say at the beginning, I will apologize if we don't get to your question. We had a wealth of questions asked, and time will not allow us to answer all of the questions, but we'll try to get through as many as we can. And so I'll ask our panelists to be succinct in giving their answers. So my first question relates to something that was mentioned several times during the presentations, and that is the GIP and different ways that it might be used to facilitate management. And I guess the question is, why is it not widely available? And that the answer may differ between Europe and North America. Maureen, do you have an answer?
I mean, sure. I think right now there's still research being done. So we still have to figure out how to best use it in the clinical situation. It's being used in clinical trials. But I don't think that we've best assessed how to use it and whether it would prevent the need for other endoscopies. So we probably need more research around cost analysis before it's available in hospitals.
And Luca, is it being used at the moment in Europe?
Yes, it is used. For example, in my hospital, my outpatient service is used, but there are different rules in different countries, of course. I think it's true what Maureen said, that now the main problem with the use of GIP, but again, I think it will be in the next future a very important tool, is the absence of a shared protocol. We don't know exactly when to use, if to use the urine, if to use the stool, how many tests to repeat, and so on. So we need a protocol, but I think in the future will be used widely.
Okay. And a question for you, from a person whose daughter was recently diagnosed with celiac disease and wants to know how she should prepare her kitchen, or does she need to prepare her kitchen to help her daughter live gluten-free?
That's a great question, because we get this from our patients, both adults and pediatrics. And what we're going to say is that you do need to prepare your kitchen, but we don't want you to exclude gluten from the house because of the nutritional, benefits of keeping those family members that are not celiac on a gluten-containing diet for nutritional quality, but also from a cost perspective. So things that would be important would be to have, designated gluten-free items, keep them, they don't have to be isolated, but make sure that things are separate. Basic hand washing of utensils, pots and pans, kitchen things is adequate for removing the gluten crumbs. And you don't need new dishes, separate pots and pans. Things that are dipped and spread need to be separate, but that's essentially it. Just careful, practical approach of keeping the crumbs away from the gluten-free food.
Good. And related to that, a question about, is there ever a place for a very low gluten diet where you avoid minute contamination but are more relaxed?
For someone maybe with non-celiac gluten sensitivity, but not for someone with celiac disease, But again, as Luca mentioned, we want you to be adherent to the gluten-free diet, but we don't want you hypervigilant. And so you need to work with a dietitian or counselor to define that line where you're maintaining your health and integrity of the gluten-free diet, but not being afraid to go out and live life.
For Luca and Mo, what immunizations should celiac patients specifically seek from their primary care doctors? Sorry, Luca, you're muted.
Yeah, sorry. I don't know if you want to start. Immunization means vaccine. Which kind of
Vaccine, yes.
Now in Italy, it's not any kind of vaccine suggested for celiac disease widely in general. Okay, not only for celiac disease. If there is a patient with celiac disease and other risk factors, of course, we decide for vaccination or not, but not only for celiac disease.
Very
Yeah,
good.
in the US, I mean, especially for children, we recommend that, all the vaccines that are recommended are given, and so there aren't additional vaccines. This is probably getting to the pneumococcal vaccination potentially. So in children, again, this doesn't come up very much. I don't know if there's a strong recommendation for adults to get that vaccine.
No, again, there is not a strong recommendation about that, only in presence of other comorbidities, not only in celiac disease.
For the most up-to-date recommendations on the pneumococcal vaccination, please see the addendum at the end of this video.
Mo, you told us about repeat biopsy and the outcomes, the findings on repeat biopsy in children with celiac disease. What I did not get a sense of is what % of your patients do you do a repeat biopsy? Is it a majority or a minority?
I think it's changing. Again, there's no guideline that says it must be done. So it's not something that we routinely do in everyone, but it's something we consider. So certainly in patients that have persistent symptoms or elevated serology or any poor growth, but we also, consider it and discuss that in adults. I believe there is a general recommendation that you could consider it after somewhere between 2 to 5 years. So I think we have that same discussion, and certainly think that going into the pubertal phase, we want to be sure that there's healing so that kids attain their maximal growth. So that's a discussion we have, but it's not something that we do for everybody. It's case by case.
A question about symptomless or silent celiac disease. What, if any, are the long-term consequences of not treating silent celiac disease?
It's nobody's answering because it's another question.
Yes.
It's difficult to answer.
Yes.
Because it's very hard to know the natural story of a silent celiac disease. That's the truth. We don't know patients who don't have symptoms, the natural story of this patient. Of course, actually, the strong recommendation is that also patients that we diagnose, for example, after familial screening, that's where they come from in general. We recommend, of course, to follow a strict gluten-free diet as other patients with celiac disease, because they maintain the same level of risk of symptomatic patients. That's the reason. But it's it's a tricky question because, again, we don't know the natural history of silent celiac disease. That's
Yes. And we know that there are many undiagnosed patients, and
exactly.
we're not aware of their presenting later in life with major complications. Although, of course, some do present with lymphoma, but it's a small number, thankfully.
Exactly. That's the point.
We heard a lot about the use of IgA-TTG in monitoring and its limitations. Does IgG-TTG or IgA-DGP, deamidated gliadin peptide, do they have any advantages over TTG, or is TTG the best available test?
I answer for adults. We don't use to monitor anti-gliadin or deamidated gliadin test to monitor celiac disease. I don't know if in children it's something.
In children, it's the same. The IgA-TTG is sort of the best, most sensitive and specific test, so that's what we use, even though it's not helpful.
Although it has its limitations.
It has limitations. Thank you.
Yeah. And maybe along those lines, we heard about symptoms, serology, and histology. Is there a hierarchy? Which is the most important of those in terms of normalization?
To be honest, another hard question, but to be honest, symptoms. If the patients feel good, that's okay for me, to be honest. But, it's, again, we have to have an holistic approach. We have not, a magic biomarker in the monitoring phase.
Mm-hmm.
So you have to look at the patients, at different points. But in general, if the patient feel good, biochemistry is okay, and so on, we don't look for mucosal healing or other things and so on.
Mm-hmm.
Here, and if I could add something too, when we're looking at symptoms, I think it's also important to evaluate, are the symptoms from gluten exposure or from other dietary aspects? Are they getting too much fiber, too little fiber, too many processed foods? So I think it's also important, we do want to see resolution of symptoms, but we also want to be able to identify the source of those symptoms.
Yeah. Yeah. And as Dr. Leonard mentioned, in non-responsive celiac disease, it's important to take a step-by-step approach and not to immediately blame gluten ingestion as the cause for persisting symptoms, but to realize that there are many different reasons why somebody may have ongoing symptoms, gluten exposure being one of them.
Right.
And there's a question here about gluten intolerance, which I think in this context means non-celiac gluten sensitivity. Does somebody with non-celiac gluten sensitivity or gluten intolerance, do they need to totally abstain from gluten in their diet? You touched upon this a little already, I think, Anne.
Yes, I think our approach to the person that has non-celiac gluten sensitivity or gluten intolerance is the basis is still that the gluten-free diet. Where it's different from our approach with our patients with celiac disease is there is a little bit more leeway in terms of that chance exposure when dining out and such. However, to go back to Luca's statement, it's all about their symptoms and their reaction, and I would really say that depending upon their reaction to any chance exposure or their reaction to, cross contact should be the driving factor in how strict they need to be.
So that's different from celiac disease,
Yes,
where we
different.
don't use symptoms to determine gluten exposure, but perhaps in non-celiac gluten sensitivity, that can be done.
Yes.
Yeah. Dr. Leonard, do you recommend genetic testing for infants who come from a family with multiple members having celiac disease?
It depends if it's covered. I think if it's covered, then it may be worth it. Some of our studies show that somewhere between 85 to 90% of these infants who have a family member with celiac disease will have one of the genetic will have genetic compatibility. It might be important if we see the exact type. We know if they're homozygous for DQ2, they might have a 40% chance of developing celiac disease in the first 10 or so years, compared to if they have one copy of DQ8, it's closer to 10%. So if you have a physician who can help you interpret the results and it's covered, then it might help you stratify their risk better, but they will likely have a compatible gene.
Yeah, most will be positive. However, a negative result can be very reassuring that the child is highly unlikely to develop celiac disease. Lymphocytic colitis, is that caused by celiac disease?
No, it's not caused. It's part of those autoimmune disorders that can be associated to celiac disease, but it's not provoked by celiac disease. And also, the contrary is not microscopic colitis inducing celiac disease.
Mm-hmm.
It's one of the autoimmune disorders that we can find associated to celiac disease. And that's the fact that usually microscopic colitis doesn't recover with gluten-free diet. We have to use budesonide or other drugs. So it's associated, but not provoked by.
Very good. And what are the guidelines for testing of first-degree relatives with celiac disease? Yep. either Luca or Mo.
I think they should be tested. We say for children, we should start testing around age 3 and probably test every 3 years or so until they're an adult. Adults should be tested, once the case is discovered, and probably with less frequency.
Yes,
Yep.
no, we usually make the same. First degree relatives should be screened with anti-tissue transglutaminase. And our advice is to repeat the screening every 3-5 years. So that's quite the same. Yeah.
We use the same approach, but again, always emphasize the family members need to make sure they're having an adequate gluten load before the testing done. Okay.
Because that's the problem, because usually when there is a celiac patient in a family, all the family reduce the gluten in
Yes.
some cases. So this could be tricky sometimes. Yes.
Yes. And as time has run out, just one final question, and that is, we heard about the difficulty in gaining access to a specialized celiac dietitian. Do you know if there are any steps and to try to improve access?
We are through the academy and through the different celiac societies. We are trying to improve that, the training of dietitians to specialize in celiac disease, and then also to, provide list of dietitians through the different areas, through the different societies and websites to make sure that people know how to get hold of us.
Great.
So things are getting better.
Good. Anne, Luca, and Mo, thank you so much for your answering those questions for us and for your presentations. And now I'll turn back to Chris Rich.
Well, thank you, Dr. Kelly. What a wonderful Q&A session. Thank you, everyone, for doing that. Special thank you to our presenters and our attendees for your participation today. We hope that all in attendance found this webinar educational and helpful. Please watch the announcement of topics and future editions of our Harvard Medical School and National Celiac Association webinar series by visiting our websites and keeping an eye on our social media accounts for updates. So from all of us here, we look forward to seeing you again next time, and thank you for your continued support.